Hello, good afternoon and good evening, everyone. My name is Paul McKenna from Accel-Heal Technologies. It is my great pleasure to welcome you to today's webinar on non-healing wounds and the role of electrical stimulation. I'm very pleased to introduce today's speakers, the chair for today's event, Professor Keith Harding and Dr. Robin Martin. We do have attendance from all corners of the world, especially Singapore and Australia, where Accel-Heal is now approved for use. So with that in mind, let's make this session as interactive as possible. Please do ask questions and share your experience. And questions can be asked at any time during the webinar by simply using the raise hand function, which you can find at the bottom of your screen. And we will pick as many of these questions up during the Q&A at the end of the session. Don't worry if you have to leave the session early. It is being recorded and will be available on the Accel-Heal website in a few weeks. So let's get started, and over to you, Keith.
Thanks very much, Paul. And can I add my welcome to you all. As usual, I'm just a warm-up man and really trying to get us into the subject of wound healing by asking the rhetorical question, why are we still struggling with this age-old problem? You can see at the bottom of these slides that I have a schizophrenic life. I spent some time in the United Kingdom and some time in Singapore, and I suspect it's because of that link into Singapore that Accel-Heal asked me if I'd be happy to be part of this, which I'm delighted to be, because what we're trying to do in Singapore is actually supportive of this particular challenge. We have the next slide, please. This is work from the UK, from the group in Wales, where we actually used a database that exists in Wales that receives data from about 80% of general practitioners in Wales. And Wales, although only a small country of 3 million, has an integrated health service. But this is where we were able to show, using this SAIL database, that 78,000 patients in 1 year saw their family doctor or general practitioner with a diagnosis wound as the cause for that consultation. Now, I have this shortcut to accountancy and economics. I'm always told the most important thing is the bottom right-hand column down here. Those 78,000 patients consumed 328 million, or 6% of the NHS budget in Wales. The interesting thing, and this is where I see it as an age-old problem and huge challenges and huge opportunities, is if you look at the cost of the dressings for these 70, less than £10 million. The bigger cost drivers are the subsequent GP visits or visits to the practice nurse, district nurse attendances at home. In our healthcare system, this resulted in 700,000 home visits from nurses. 20 million for the cost of outpatient attendances, 68,000 of those, but what was achieved are nearly 15,000 admissions. And what we would argue is that one of the challenges that we face here is we have to look at changing the provision of care, as well as appropriate selection of product interventions that may assist in healing. Next slide. This is another if I can have the next slide. This is another paper we published a few years ago, where we looked at over 8,000 patients across the whole of Wales in 66 hospitals to say that we had a point prevalence of pressure ulcers of 8.9%. So that's nearly 1 in 10 hospital beds were occupied across the whole country by patients with pressure damage. Most people who work in this area would say that the majority, if not all of those, are preventable. Worryingly, and again because of the profile of the subject, the design of this particular study, we inspected the skin when it was appropriate, and 18% of the pressure injuries we found weren't documented, and of the ones that we did found, a further 18% were documented inaccurately, and 50% of the patients developed their pressure injuries while they were in a hospital bed. We also had around 30% of all hospital patients had a wound of one type or another, not specifically pressure injuries. So here is at the scale of the problem. Something's potentially preventable, something is recorded inaccurately, and there's still huge opportunities for improvement. Next slide. This is work from Julian Guest, well-known papers looking at a different database, the thin database in the United Kingdom, and looking at the annual NHS spend in billions, comparing wound care with cancer, with obesity. And the interesting thing, 5.3 billion, and we're up there along more or less the same ballpark as the cost of cancer. Why is the profile of cancer so much greater, so much higher than that of wounds? The bottom half of that slide is important because Julian and Peter Bowden published a follow-up where they went 5 years later back to show this with the same database. There was a 70% increase in the numbers of patients with wounds and a 45% increase in costs. So this is a problem that's increasing in number, increasing in cost. We have not cracked that challenge. Next slide. This is where I'm part of this wound care innovation in the tropics, which is a large program grant in Singapore, which enables us to bring together under 3 programs. Next slide. A series of activities that are around wounds in Singapore. But the important thing, we've chosen Singapore because Singapore had data to suggest that they were spending $1.1 billion Sing dollars on wound care. And there was interesting challenge is that in diabetic patients in Singapore, Singapore residents had the highest rate of, second highest rate of major amputations in developed nations. And the important thing is to recognize that the problems in tropical countries may be different from the problem in temperate countries, although it's not very temperate in the United Kingdom today, I can assure you, as I'm melting with no air conditioning. Next slide. We've actually been shown by this group from the National Health Group, Tan Tock Seng Hospital, is that setting up a dedicated diabetic foot limb service could have a big impact on reducing both major and minor amputations. So there is experience, evidence, data out there that says you can make a difference by actually having a focus on this common, expensive and neglected problem. Next slide. This is the 3 components of the wound care in the tropics program. I'm the principal investigator leading on the clinical application of this. And one of the things that's important there was to develop a wound registry. One of my mantras these days is when you're trying to get people to think about wounds, if there's no data, there's no problem. Get the data, and almost more importantly, get government data to say it's your figures that tell us it's that common, it's that expensive. It's difficult for the politicians to wriggle out of it. But that has to be linked with enabling technologies and development of tools, devices, and therapies, which all help. And it's the integration of these 3 programs, which in our opinion is what's needed to produce that transformation that can be achieved in the development of wound healing services in different parts of the world. Next slide. The interesting thing, and I see Annie Joseph's on the list of delegates, she's the commercial director of this thing. You can see that they've already started to make success in terms of industry contacts, filing patents, technology disclosures, winning awards, and publishing and presenting papers. So we are creating an ecosystem in Singapore where wounds are seen as an important issue. Next slide. This is also important because this is what I consider is the highlight of this piece of work, where we actually are saying that we've got a 5-year institutional population health review looking at this. Next. And this is from the National Health Group with TTSH and NHG polyclinics. You know, the delegates on the call from Singapore know this better than anybody. But the important thing is that they've been working in this area for some time, and they've got these data to suggest this is a problem for them. Next. And the important thing is they collected data in a systematic way, created a wound registry. Next slide. And what they've been able to show over time, and this is Joseph Lowe's work and others from TTSH, where they've shown from 2013 up to 2017 in this slide, is the variation in incidence and the charges to patients. The one thing I'm interested by is the fact you go to 2013 average length of stay and 2017 average length of stay, it hasn't changed that dramatically. And the cost has gone up and the numbers have gone up. Interesting, big problem that's not going away. Next slide. And this is further data from it. And one of the things that's important is not only about age and race, but also gender. This frailty index is important because look at the number of patients, the percentage of patients, more than 50% of them are either moderately or severely frail. And this thing that's really depressing for some people, not for me, I see it as a great challenge, is this Charlson Comorbidity Index says that these patients have on average 7 other diseases to address as well as their non-healing wound. These are complex clinical challenges. Next. This is the paper that I'm probably most proud of to date from Singapore. This is using the Ministry of Health records in Singapore to be able to identify the epidemiology of wounds in Singapore, published in 2018, sorry. Next. And here again, we were able to track over time the number of patients with wounds and the age-adjusted rate of wounds, again suggesting that there are problems that aren't going away. Next. We have vision for this wound project going forward. We want to link the wound assessment with the electronic record. We want to strive to and create a prospective national wound registry, and we've just managed to recruit about 840 patients into a prospective registry with patients recruited from 3 clusters. We're building teams, we're creating a network of Asian countries on wound healing, and creating a wound center of excellence in Singapore. All of these are big, ambitious plans, but generally feel we have the opportunity of making a difference there. Next slide. This is what I dream of. I wake up in the middle of the night thinking this is what we should be aiming for if we're going to provide patients with good care. Because if you change wounds to cancer or heart disease or diabetes, this is what actually happens to patients. And this is something we need to create to enable patients to get good care. And it's not only good care, but it's also a selection of the right treatment for the right patient at the right time for the right reason. Next. And that brings us on to pressure ulcers. Ugly pressure ulcer, those are a word salad of things people describe about pressure ulcers. Next slide. And this is interesting because you go back to the first one I could find of a description of pressure ulcer comes from Egypt, where it was a single case report where they used gazelle skin. Didn't know of evidence-based medicine in those days. Next. And I'm still left in my practice, and I suspect you are in yours, with these 4 patients here with pressure ulcers, which one won't heal, which one will heal, and what is the right treatment to get them to heal. Next. The other thing that's interesting is the potential for litigation associated with pressure injuries as an avoidable complication of patient care. And we need to recognize, although that shroud waving can have a negative impact, it is something we should grab hold of to actually drive forward the interest in pressure injuries as a component part of this wound challenge. Next. And I was the first president of the European Pressure Ulcer Advisory Panel, and we first created guidelines in 1998, which have subsequently been surpassed by ones in 2009 and 2014. And the interesting thing about pressure ulcers, and the interesting about these international guidelines, next slide, is the fact that what we recognize is that we're still learning about these things. This is looking at 2009 to 2014 and looking at new recommendations, ones deleted and rewording, and 50% of those had changed from 2009 to 2014. So the picture isn't clear at the moment. The picture is becoming more clear as time goes on. Next slide. And this is interesting in terms of A-level strength of evidence in 2009. These 4 subjects, topics listed on the left are the only aspects of pressure injury that had a level of evidence. I'll just point you to this. Consider the use of direct contact electrical stimulation to facilitate wound healing in recalcitrant pressure ulcers. How many of you were aware of that? And how many of you actually look at patients with pressure ulcers and spend your time and energies focused on what mattress or what bed that you're going to care for them on? But look at the level, the subjects that had level of evidence. Next slide. This is the evidence for support services. High specification reactive foam mattress. Can't tell us any more specific things than that. Next slide. And this is the interesting thing about evidence-based medicine. The triangle in the bottom left is the hierarchy of evidence as normally seen, but we've changed it from the translation of research into practice. So this is the fact that you get large numbers of people aware, less numbers accepted, less numbers that are applicable, the particular challenge they're looking at is applicable, able to make a change, they're acted upon, they're agreed, and they're adhered to. This is the true extent of evidence-based practice and not necessarily the straightforward triangle with a systematic review at the top of that file. Next slide. And the interesting thing, and this is where I want to finish up by saying, that at a time where we're dealing with COVID, we're dealing with challenges of growth of organizations, provision of healthcare, economic crises, and climate change. One of the things that we need to address is the problem of wounds. We also need to recognize at the current time, the way in which we provide care to patients with wounds still has a huge room for improvement. Here we have a technology, and Dr. Martin will now give us a bit more detail about it, to show the science behind electrical stimulation. I've shown you guidelines that are more than 10 years old. But why aren't we recognizing those guidelines to influence the way in which we change practice? So my privilege as being chair is I now throw the challenge to Dr. Robin Martin and say, Robin, convince me there's a scientific underpinning, convince me, you give me some clear steer of when and how I should use electrical stimulation to treat my patients who have non-healing wounds. Robin.
Okay, thanks very much, Keith. Well, I will certainly take up that challenge. I think I've been in wound care and tissue engineering for 25 years as an academic and also in industry. And I think until Accel-Heal Technologies approached me to chair their clinical and scientific advisory board, I'm now a freelance consultant. I think it's fair to say I didn't really know very much about electrical stimulation and wound healing. I'm going to give you a quick run through of what I've learned over the last couple of years. What we're going to do in today's 25 minutes from now, look at what role do electrical fields play in the phases of wound healing, talk about what is known already about the mechanisms of action, and I think you'll find that there's quite a considerable amount already known. And then we're going to review just one single-use electrical stimulation device for wound healing and, interestingly, pain reduction. So next slide, please. So I'm going to begin the story about bioelectricity because the key thing about this is to understand that our bodies already run on bioelectricity. Our wounds already heal in the acute, the normal phase of wound healing already includes electrical stimulation. It's generated by the body itself. But one of the areas which has been developed, quite a considerable knowledge of how electrical stimulation affects tissue growth and repair is in the whole area of development and regeneration in animals. Developmental biologists have been looking at this for many years, and they find that patterns of cell movement in animals can regenerate an entire limb, are often coordinated by endogenous electric fields. In the picture there, you can see one experiment in an animal like a frog, who doesn't an adult frog doesn't regenerate their limbs if they're amputated. However, in these experiments, they found that by applying a certain pattern of electrical stimulation, they could get a frog leg to regenerate bone and muscle, whereas controls just healed with a scar. So bioelectricity is already an important part of normal physiology in tissue. Next slide, please. And one of the first sort of avenues to intersect with human wound healing was in probably this is about the only area in human physiology where there's anything approaching regeneration of a limb. As you know, humans do not regenerate a limb, but in children, if you have an amputation at the tip of the finger, they can regenerate if you treat them conservatively to regenerate, you know, bits of bone, muscle, and fingernail. And when people looked at those injuries and they measured, they were able to measure a small electrical current of the order of microamps per square centimeter. And these currents, as you see in the left-hand side of the slide, can be detected in the wound for several days. So electricity is present in wounds, in normal wounds. Next slide, please. And further analysis found that actually, if you survey the whole of the surface of the human body, that in the healthy state, the epidermis is really holding, almost like a battery, a small but consistent voltage between the upper and lower layers of the skin. Studies have mapped the voltage around the body and found, you know, an average of about 23 millivolts. Males and females are similar, as are younger and older people. And this is often, this phenomena of a stored electricity in the human body is often referred to as the skin battery. Now, next slide, and we'll see what happens when you have an injury. So you breach the barrier between the epidermis and the dermis, and current then flows into the center of the wound where the epithelium has been disturbed. And so the skin battery is formed, we now know, because of the asymmetric distribution of sodium, potassium, and chloride ion pumps in different epithelial layers. So sodium tends to be pumped downwards through an epidermis, and chloride ions tend to be pumped upwards. And when you wound the epithelial layer, that stored current flows into the center of the wound, and that's called the current of injury. In human wounds, the current can reach about 10 microamps per square centimeter after about 3 hours. And we generate about 10 to 100 millivolts per millimeter at the wound edge. So next slide. What people have begun to do is take cells which are involved in wound healing and expose them to those kinds of voltages and currents in tissue culture. And this is one of the first papers. And quite significantly, I think, is that they were able to show that electric fields can switch on both growth factors, but very importantly, they switch on the expression of receptors for growth factors. So this is clearly the way that wound healing is orchestrated. It seems that bioelectricity released at the point of injury is preparing the tissue for wound healing by expressing the growth factor receptors for the growth factors that are going to coordinate wound healing. And you can see there in the picture on the right that using a fluorescein EGF binding, you can show that under an electric field, the growth factor receptor for epidermal growth factor is located on the side of the cell facing towards the wound. So this is another important aspect of endogenous bioelectricity. It seems to be able to inform the cells, which is the center of the wound, and it also prepares the cells for the things that they're going to need to do to go through the phases of wound healing to seal the tissue. Next slide, please. Looking very carefully at the epithelial edge, and corneal wound healing systems, because they're transparent, have been utilized extensively. And a key technique is using drugs that affect the activity of the sodium or chloride ion pumps to either activate them or inhibit them. And Song et al., which is a classic, this is a classic paper that appeared in 2002, were able to show that increases in the gradient of the bioelectric field at the wound edge allowed and caused cells to divide more frequently, align with the direction of the wound edge, and migrate faster to close the wound. So this is evidence that endogenous bioelectricity is part of normal wound healing when you have an acute injury in mammalian skin. Next slide, please. Similarly, I could pick many different papers. Here you can see evidence that in electrical stimulation, you produce vascular endothelial growth factor, very important for angiogenesis, bringing back new blood vessels. And not only do we see changes in activity and division, you can see that the center field on the right-hand side, looking at the phase contrast microscope pictures, you can see that under an electric field, the orientation of the cells responds substantially, and you get a parallel alignment compared with the current. And evidence has shown that that is to do with the interaction of VEGF with the receptor because it's blocked by the inhibitor. Next slide, please. Here is a classic paper, and if anybody thought that maybe bioelectricity and wounds is a little bit on the fringe side of wound healing science, note that this paper was in the science journal Nature, and you will be able to find online videos of this series of experiments, but I didn't want to chance feint and have a video playing over the webinar today. But what they did is, using the very familiar scratch assays, they can put different cells down, and as you know, if you scratch the cells off in a tissue culture dish, the cells will then, in a combination of proliferation and migration, close the gap. However, if you apply an electric field across the gap, you can either get the cells to close more rapidly, or if you reverse the field to the way that they're normally expecting, you can get the gap to remain open and in fact get bigger. So it's really important that bioelectricity really can control epithelial migration. And if you look at the next slide, a really important point is that this isn't some, some sort of hand waving, sort of spooky, sort of ununderstood mechanism. These type of events are coordinated by well-known pathways. These are the pathways that people know about how cells stop growing, start growing. They're all to do with phosphorylation by the PI3 kinase, and they're inhibited by dephosphorylation by the P10 phosphatase in this example. And you can see there that electric fields are able to coordinate and condense phospho SRC, the SRC protein, which is really critical for cell migration. So the real take-home message is that bioelectricity works through well understood mechanisms in biology. Next slide, please. Now, how about evidence for bioelectricity in human situations? A very nice set of experiments that's been done in a series from the University of Manchester in the United Kingdom by Dr. Ardeshir Bayat and his group. They have a human punch biopsy acute wound model. Other people have done that around the world, but they've used it particularly for looking at electrical stimulation. What you could do is, with all the proper ethical approvals and guidelines, you essentially bribe students for a few tens of pounds of sterling to have punch biopsy wounds made on their under their right and left upper arm. And then those tiny punch biopsy wounds undergo acute wound healing, and you can then go in and using, if it's a 5mm punch wound, you can use a 7mm punch to collect the biopsy, pay the student some more money, and then you can take those biopsies away and subject them to all kinds of histology, immunohistology, molecular biology. as well as all sorts of non-invasive analyses. And because the individuals have both right and left arms wounded in that way, you can randomize active or inactive devices. So next slide, please. So in this experiment that was published in 2011, they did this study and had one particular electrical stimulation device active, and randomized the other arm to receive an inactive placebo device that looked the same but didn't actually give the electrical current. And so each patient is their own control. It looked at many different genes. There you see fibronectin, collagen 4, essential for epithelial migration and building basement membrane. And in the right hand, and they were at 14 days of electrical stimulation, they were massively stimulated. And on the right-hand side, you can see the different phases of wound healing there, inflammatory phase, proliferation and granulation phase, and remodeling phase. And the two boxes on the right-hand side of that diagram, the non-stimulated day 14, that's what the controls look like. And with electrical stimulation for 14 days, you see that the wounds have advanced, and they're now, like a control wound would be about 4 or 5 days later. So even in acute normal wound healing, stimulation with exogenous bioelectricity, because there would already be some bioelectricity in those wounds as they're healing, can make wound healing faster. If you go to the next slide, please. Here you can see on the left-hand side, and there were only 20 volunteers, so it's a very powerful statistical technique. You can see that wound diameter reduction is statistically significantly faster by day 10 and by day 14 with electrical stimulation. And also you can measure all sorts of different things. Here is the immunohistochemical analysis of angiogenesis, significantly greater with bioelectric stimulation. Next slide, please. Now, what we're talking about, if we want to help solve some of the the clinical problems that Professor Harding introduced us with, we need to really go to clinical trial evidence for electrical stimulation in these hard to heal chronic wounds. Now, unfortunately, there haven't been substantially large studies. Chronic wounds are a devil to do big randomized controlled trials on, because you really need to have an enormous number of patients to smooth out all the different comorbidities. Professor Harding said some patients have 7 comorbidities. Very difficult to allow for all that and getting your randomizations in balance. So what people do, as I'm sure you're aware, is they look at a number of small studies and try to put them all together and do a meta-analysis of small studies to see if they can make any sense of it. And Cole and Houghton in 2014 did a big study, and they looked at 15 different randomized trials, and they looked at the percentage area reduction in 4 weeks to try and find a common endpoint throughout all of the studies. And if you just flip down and look at the right-hand side at the forest plot, you can see that 14 out of 15 of the different electrical stimulation studies in chronic wounds, and there are different types of chronic wounds. Some are foot ulcers, some are mixed, some are venous leg ulcers, some are pressure ulcers. But you see every single one of those 14 studies lies to the right of the vertical line. And you can see that on average, electrical stimulation closes the wound in the first 4 weeks faster than the controls. So that's quite powerful evidence. And as Professor Harding said, in the UPAP guidelines, electrical stimulation is one of the few technologies to receive, a grade A evidence rating. So if we flip to the next slide, The other thing that's really important about wound healing, and this is a paper that with some colleagues we've just had published in Journal of Wound Care. Another thing that is frequently observed during the use of electrical stimulation is that many chronic wounds have pain. Venous leg ulcers are a classic one. Many venous leg ulcers are very, very painful. The patients hardly let you touch them, let alone put high strength compression bandaging on. We did a look in the literature and found 7 studies, 3 comparative and 4 randomized trials, and they all reported a quite rapid reduction in pain. And the important thing about using electrical stimulation for reducing of pain, for example, it might make more patients tolerate compression therapy. Now we know in venous leg ulcers, compression therapy has the most grade A evidence for just about any technology in wound healing, yet it's poorly used. Many nurses will back off the compression because the patients are screaming at them saying, no, I can't stand it, it hurts too much. So one of the things that is really an interesting prospect is, can we use bioelectricity to reduce the pain and allow people to tolerate these therapies? Next slide, please. So after hopefully I'm beginning to convince you that there's something in this bioelectricity and stimulation. So why haven't we all been using it much more widely? So there are a number of reasons. The clinical study, a clinical trial I showed you in the meta-analysis, there's probably about 10 different devices there. So no one device has become universally accepted. The other issue is that many devices need a clinic-based or reusable console. So for example, the guy sitting there having his electrical stimulation on his leg, I think that's probably a volunteer, but you can see that device, very effective that it is, very clinically effective stimulating wound healing, needs a suitcase to wheel it around. Well, with the best will in the world, that's not really one thing that's a very good model for industry. And 2, it's not very good for getting people home and to be wound healing and, you know, in their own surroundings. So the scientific mechanisms are not widely understood, but we really do need to do better if electrical stimulation is going to be more widely used. And the next slide will show you the device from the company that the sponsors of this webinar. So the Accel-Heal is a single use, and it happens to be a low voltage pulse current device. We'll talk about that more. It comes with 6 little devices, enabling you to use one for 2 days each, and that gives you 12 days of therapy. And the costs of this are about the same per day as a single use negative pressure wound therapy system. And the Accel-Heal device, you know, is automatic. You switch it on, and then there's no changes to make. You know, automatically delivers electrical stimulation to the wound. And quite importantly, it's a subsensory level. If you had this on you now, you would barely be able to feel it, and that's quite important. And so it's important to understand that, you know, the manufacturers for this device are not claiming anything better about the electrical current or the electrical stimulation, but it's a simple to use and easy to use format. And just think about how single-use negative pressure wound therapy is still the same wound therapy as you get with a big negative pressure wound therapy pump, but it's in a much more convenient format. And that's really key to getting things used in healthcare systems. Next slide, please. Just look at this time. Now, you would have noticed that in the studies that I showed you about the molecular biology and the understanding in vitro of and the current of injury, these are all what we call direct currents. So, you know, there's positive and a negative electrode, and there's a voltage between them and a current flow. However, when you find that you have to try and deliver electrical stimulation to the skin, everybody has found that if you used a pulse that switches on and off, often quite rapidly, they use pulsed currents. It allows you to apply current without leading to skin problems and skin breakdown. So all the clinical data I showed you, and including the Accel-Heal device, use pulse current fields. A really important paper was published by Ren et al. Just a couple of years ago, and they showed that even in vitro, if you use pulse current, it actually stimulates, here they're looking at phosphorylation of a protein called p-ERK, which is very important for activating wound healing in different cells. And so pulse currents work just as well, and all the same biology applies. Next slide, please. Now, just let's look for a few minutes about the Accel-Heal device, the single-use device that we're focusing on now. It actually is an example of what we call a low voltage, biphasic and monophasic pulse current system. That sounds a bit of a mouthful, but essentially what the developers of this have tried to do is, because it's difficult to predict, or we just don't know enough about the exact currents and the exact pulses that would be ideal for all the different tissues in different places on the body, this device is sort of, gives you a bit of everything. So it starts off with a rapidly changing sequence of pulse steps going from 40 to 500 microamps. And then there's a period in the middle. This is in a sort of about 30-minute therapy. Then in the middle, there's about 20 minutes of monophasic. So that's the current is just going up, on and off in one direction. And then finally finishing with this biphasic bit. It's not so, not really important what the current is. And I have a sneaking suspicion from all my readings that it's important that there are changes in field strength and current, but I'm not yet convinced that any one is better than the other. The important thing about Accel-Heal, it's in a simple and easy to use device. And just with one press of the button, the clinician can set all this off and it just is automatic. Next slide, please. Okay, so here's the application, and I think on the in the Q&A that we come to, there will be some experts that have used Accel-Heal quite considerable time. Very, very simple. It connects to 2 electrodes. The device has a simple press, and there's some flashing LEDs to tell you whether it's working or switched off. You apply the electrode pads to the intact skin near the wound. Now, this is the clever bit. The Accel-Heal device monitors the current flow between those 2 electrodes. You can see on the right-hand side, the 2 electrodes. It monitors it and then automatically adjusts the voltage to ensure that the same current is given. So you could imagine if you decided to put the 2 electrodes down, further away, would the wound see the same current? Well, you don't have to worry about that with this device because it automatically senses what the current flow is and then adjusts the voltage continually to make sure that every patient gets the same therapy. Next slide. So what about clinical evidence for wound healing with Accel-Heal? Well, a few years ago, before I joined, there was a small randomized study done. And just as I said, sometimes randomized studies are difficult to control with lots of comorbidities. In this study, for whatever reason, the active device group ended up with bigger and older wounds than the standard care group. So what that meant is that the proportion of wounds that healed was the same in both groups. However, when you dived in deeper, you found that the Accel-Heal treated wounds actually healed faster, and the wounds that healed did so 3.5 weeks faster than those in the placebo group. So there's quite a bit of evidence that the electrical stimulation was able to stimulate a closure of those wounds. And these wounds were all venous leg ulcers, I should say. Clearly, we can always do with more evidence. But the next slide also touches on what I mentioned earlier. Here you can see this was 51 patients with leg ulcers. This was pooled data from a number of evaluations in the United Kingdom. You can see the wounds wound area reducing in the left hand. But the critical thing I wanted to turn back to was the reduction in pain. And you can see there on a 10-point pain score at the start of treatment, there was 7.59 was the mean pain score. And within 2 weeks, the pain score was down to 2.8. And that's really sometimes the difference between patients accepting and tolerating full strength compression. Why might that pain reduction be occurring? Next slide, please. Well, a couple of years ago, a study was published that used the Accel-Heal device, and this was on volunteers. And the volunteers didn't have wounds, but they had either the active device or a placebo device that looked the same but wasn't giving electrical stimulation. Very important to do high quality studies in this area. And then at the end of 48 hours, then biopsies were taken of the treated areas. And what it was found was that electrical stimulation had reduced the expression by about between 3.5 and 2.5 fold of about 30 genes. And what characterized those 30 genes was very prominently the biggest reductions were in genes like the S100 genes and SERPIN-B4 genes, which are known markers of inflammation in cells. And S100 in the next slide just happens to be in a study, a Japanese study by Goto et al. Was shown that if you measure the level of S100 protein in the exudate from venous leg ulcers and ask the patients to score their pain, the higher the pain intensity, the more S100 is present in the wound exudate. So this is a possible reason why if Accel-Heal, and you apply it to wounds, reduces the expression of the S100 gene, it might be the beginnings of a molecular understanding of how that works. Next slide, please. So just some last thoughts before we finish. Just to remind you that normal wound healing, as you see that cascade that we're all familiar with, the different phases, relies on bioelectric signals, normal signals in the tissue to direct immune cell migration, angiogenesis, granulation, tissue synthesis, keratinocyte migration, and proliferation. That already happens with bioelectricity. So adding exogenous bioelectric fields, it does accelerate progress through the normal phases of wound healing. We know that. That was in the biopsy studies with the students. Normal wound healing can be speeded up by applying electrical signals. And in chronic wounds that have been around for many weeks, there's some evidence, but this is an area that should be explored more. There's some evidence that the bioelectricity has ceased to flow. In other words, the battery's flat. Now, that makes a perfect rationale for why you might need to apply some bioelectricity. I don't think any of us would be naive enough to say this is a magic bullet. If you subscribe, like I do, to the TIME way of thinking about tissue, infection, moisture, and the epithelial edge, there's multiple things that you've got to look at to stimulate wound healing. But I wonder whether it would be a bit naive now to ignore the possibility that there is an element of electrical stimulation in normal wound healing. And should you contemplate that when you're thinking about how to tackle certain wounds? And I just wonder whether the E in time, which I know people over the years have debated what the E in time means, one of the things that it might mean is electricity. So I'm finishing there and going to hand over to Professor Harding for some Q&A about the whole area of what we've both presented. Thank you.
Thanks very much, Robin. Very comprehensive and lots of stuff for us to take on board. There have been some questions already answered in the live discussion, as I understand, by Paul. can I just kick off while others, please ask the questions, is I'm sure the students in Manchester weren't bribed, all right? I'm sure they were given recompense for inconvenience and travel. That's what
exactly.
all right? And the interesting thing from that data is you didn't see a difference with electrical stimulation until 10 days. Other parts of your presentation, you're saying the electrical stimulation has effects across the whole spread of processes involved in wound healing. Why did you have that delay, do you think?
Well, I think, as you know, a fit, young, healthy student, wound healing goes pretty fast. And I think in some of the other analyses, they do begin to see things like gene expression changes earlier on. But I think it's just not you're not able to see in macroscopic wound area reduction. It all goes too fast to see it.
Okay, thanks.
Yeah, Keith, I think you've mentioned that I'd answered the questions. I haven't actually, I've just moved them across.
Okay, fine. All right. I will let's pick some of these things up. Dr. Kurtz from Austria has had experience of using this device on 20 case studies. 18 have closed. Do you want to add anything to that issue that you've raised there? Because you obviously had a very positive experience.
Yeah, Joe, I don't know if it's possible to allow Peter Kurtz to speak. But in the meantime, I think he'd made a couple of other comments. Peter had made some other comments.
Okay, while we're trying to get that sorted out, another question from Sandra Boscovin is, what is the efficacy rate of this treatment? Can we set up this treatment at what cost? Do you want to pick that up, Paul?
Yeah, I think it might be good if Rob chose to speak to the efficacy rate, and then I could pick up on the cost side.
Yeah, I mean, I mean, Peter Kurtz, who I think is probably unmuted now, has been one of the investigators, starting to use this, and I think he's used it across a number of wounds. I think the important thing is that whenever a wound of whatever type has sort of run out of steam and is stalled, you need something to reactivate all those pathways. And quite remarkably, I think, repeatedly, I see people who come to show a wound which has stopped and stalled, and they've tried, and these are experienced users of all kinds of different technologies, and then they try electrical stimulation and they find the wound wakes up. It does not the end of the story. They still need all their skills to take it to closure, but the wound really does wake up. Peter, I think if you're able to make a couple of comments on that.
Okay. Yes. Can you hear me good?
You can indeed.
Yes.
In 14 days, I will present you our results from the case studies. But what I can say is that we see significantly better metabolism, reduction of sign of inflammation, and sometimes extremely rapid improvements in approximately 80% of cases. What I can say is everyone benefits, yes, but there are always significant changes. It's very impressive, yes, what I have seen in the last month.
Okay, so is it been a game changer as far as you're concerned, Dr. Kurtz, based on this recent experience?
Yes, it's absolutely a very good device, and extremely good for a good wound healing to kickstart the wound healing. It's not the only one what we can do, but a necessary device for a top wound healing.
Okay, thank you for that. Can I move on to Dr. Wan Marawi? Robin, is there any problems or risks as using this device in patients who have malignant wounds?
Well, that's a really good point. Similar to the warning on negative pressure wound therapy devices, Accel-Heal, because it stimulates angiogenesis, has a contraindication for use of malignancy and tumor in the wound. Of course, a clinician can override that for compassionate grounds, but it would be you wouldn't be surprised if it might stimulate angiogenesis, with tumors in the wound. But that is similar to other type of devices.
Okay, thank you for that. Another question is Accel-Heal capable of promoting healing after the 12-day cycle of therapy? So is there an ongoing effect, or do you have to give it a boost every now and again to try and move the wound forward?
Well, if I ask from what I've seen, people find that you can often get the wound back onto a trajectory, which and now, almost the intrinsic processes of healing, as long as you're doing all the things you should be doing, removing, exudate and keeping the wound free of infection. But you often do get quite a long lasting, reduction in area and trajectory. However, if you begin to plateau again, I've certainly seen clinicians present cases where if you plateau again and the wound has stalled again, by all means, apply another 12 days of therapy, and you often find then the wound gets back onto a healing trajectory. Okay,
so it kickstarts it may tail off, kickstart again, and you can give repeated cycle.
That seems to be the way, yes.
Okay.
I think, Paul, you were going to something about the cost.
Yeah, I certainly will. I was just proving a question there. Yeah, the cost in the UK is £240, but this is for a one-off 12-day treatment. And within the United Kingdom, we have done a number of cost-effective evaluations based on the randomized controlled trial, primarily focused on venous leg ulcers, and the cost saving per patient was actually £936. So there was a considerable cost saving. Conscious for every product now, you have to be able to demonstrate value, and that can certainly be done for electrical stimulation. Other wound groups have been looked at. There was a Cochrane review, for instance, on pressure ulcers, which actually showed similar cost savings when using electrical stimulation.
Okay, thanks for that, Paul. I'm just conscious of time ticking by. I want to get some more in. In the clinical studies you described, Robin, was the Accel-Heal used in combination with any specific dressing, cream, or foam?
I think in most of the studies, and this is really a sort of key ease of use aspect of Accel-Heal, it doesn't have a dressing, it doesn't come with a dressing, but what that means is you can use it with your preferred dressing. So you could use it, for example, we've seen cases of Accel-Heal used with traditional negative pressure wound therapy. Sometimes even negative pressure runs out of steam. You can simultaneously give Accel-Heal electrical stimulation, and then you see exudate move, again. So the key thing about Accel-Heal is that you do need to use your own wound dressing or whatever. But the critical thing is, unlike some electrical stimulation devices, you're not mandated to use the one provided by the manufacturer.
Okay, thank you for that. And to follow on from that, is it appropriate to use Accel-Heal in conjunction with other advanced wound therapies such as Natrox oxygen delivery system or negative pressure therapy?
Well, I can't speak about the Natrox system. Of course, you have to just make sure that there's no issue with electricity. But I know we've done ourselves with volunteers, just to make sure that everything works okay. You can certainly use Accel-Heal in conjunction with negative pressure wound therapy, and they do not interfere with each other.
Okay. Just finally from me before we have to wrap up, is I may have missed it. When you were talking about the pulse current and all the various things and resting, you said about skin damage. What skin damage you get? You get breakage of the skin or heating of the skin or what?
You can get skin damage when you try to apply constant currents. But nearly all the clinical devices that are being used use pulse currents. The one thing about pulse currents is it seems to be that the higher the frequency of the pulse, the deeper the current flows, and that can be quite important for treating deeper wounds.
Okay, thank you for that. I've learned a lot from the last hour. hopefully the delegates on this webinar have learned. We've got nearly 80 people on this call live, and I'm sure lots of people will look at it after the event. I'm grateful for Robin for his presentation. I'm grateful for Paul and Accel-Heal sponsoring this thing, and as being kind and generous as always. We should let Paul have the last word as we're finishing on time.
Oh, thanks very much, Keith, and I'd just like to thank everybody for their participation and joining today. Appreciate it's quite late in Australia now, so really great effort you guys in joining. The session's been recorded, so if you have missed any of it, it will be available on the Accel-Heal website in the next couple of weeks. And we have recorded everybody's questions, so apologies if we're not able to answer them all today, but we will certainly come back to you all afterwards with a detailed answer to any of your questions. But if you've got any other questions after this webinar, please just reach out to us and we'll be happy to support you. But thanks again.
Thank you.
Goodbye.